Hello everyone, this is Dr. Immunist again. Let us now see the differences between GBS and transverse myelitis. Okay, as both are acute onset neurodeficits and both are autoimmune nature, right? And which both can come after a preceding infection. Right, we'll see what are the key differences. So coming to the GBS definition, if you see, it is immune-mediated demyelination or axonal degeneration of peripheral nervous system, which particularly affects motor or sensory nerves. Whereas in transverse myelitis, there is inflammation that is acute onset, but one or more segments of the spinal cord we are talking here, which results in motor sensory autonomic dysfunction, which is below the level of the lesion. Right. Pathophysiology, both are autoimmune, as I said. Okay. But in GBS, the autoimmune attack is against the peripheral nerve components like myelin or axons. Okay. Whereas here, the post-infection inflammatory process which targets the spinal cord. Okay. And GBS is, as you see, molecular mimicry. It is associated with that after infections like Campylobacter jejuni or CMV infections. In TM, it can be idiopathic or can be associated with other autoimmune disorders like lupus, neuromyelitis optica, multiple sclerosis, Sjogren's syndrome, etc. So, affecting sites, as I said, peripheral nerves are affected here, and cranial nerves can also be affected. But here it is spinal cord segments, right? Onset, both have acute, but GBS can also have subacute, means it will progress slow and it can evolve up to days and weeks. Whereas in TM, acute, rapid onset, and often it progresses over hours and days. Okay, clinical features we see one by one. Weakness, if you see, it is progressive ascending paralysis starting from the lower limbs and then moving upward. Whereas in TM, it is acute paraparesis or quadriparesis depending on the segment affected, and it is often symmetrical weaknesses there. And usually the limbs are affected below the level of spinal cord lesion, right? Which segment is affected, below that the weakness will be there. Reflexes, they are markedly absent, but overall, okay, all the body reflexes are absent or diminished. But whereas in TM, reflexes are diminished or absent only below the segment affected, right? Sensory symptoms, mild sensory loss can be there. Okay, but if you see in the TM, there is a sharp sensory level deficit. I mean, the patient will tell, suppose T10 is affected, T12 is affected, and below the umbilicus, he'll say that there is no sensation at all. So that sharp demarcation suggested of transverse myelitis. Cranial nerves, as I said, it is common in GBS. So patient might have bulbar palsy or facial weakness, dysarthria, dysphagia, and all. Autonomic dysfunction can be there in both, but if you see bowel and bladder dysfunction, which is more common in transverse myelitis and less common in GBS, but other symptoms like tachycardia, blood pressure fluctuations, urinary retention, so this tachycardia or bradycardia or increased or decreased BP will be common in GBS. Okay, other than that, back pain is more common in transverse myelitis. Frequently, at the level of lesion it will be. Okay, back pain can also be there in GBS, but not that typically present. GBS, other than that, respiratory failure. Okay, patient might progress to respiratory failure, and that is where our concern. I mean, it is our active approach, and you have to treat the respiratory failure either by intubation, right? Now, coming to the diagnostic clues, if you do the CSF analysis in GBS, what pathonomic feature will get is albino cytological dissociation. That means what? The albumin, which is a protein which will increase, but cytological, that is cells won't increase. All other components will be normal in CSF, only the protein is increasing. Okay. Whereas if you see in transverse myelitis, there will be pleocytosis and proteins will obviously increase. The cells will increase in TM, but not in GBS. Now, if you do the MRI, typically GBS MRI will be MRI spine will be normal, or mild nerve root enhancement can be there sometimes. But in transverse myelitis, there will be spinal cord edema and inflammation of the affected segment. right? Then nerve conduction studies, it shows slow nerve conduction velocities, that is a sign of demyelination, and prolonged F waves latencies. In TM, nerve condition studies are usually not necessary or not done. Okay, even if you do that sensory somatosensory evoked potentials, you will see that delayed conduction across the spinal cord lesion. Right. Now, common preceding in factors, as I said, infections are common in both, but TM can be also associated with other autoimmune disorders like SLE, Sjogren's syndrome, multiple sclerosis, and NMO. Electrophysiological, I just now discussed, which is not commonly used for diagnosis in TM, but if you do somatosensory evoked potential, it will show delayed spinal cord pathways. I mean the delayed nerve conduction at the level of spinal cord involved. Next is autoimmune dysfunction, which is like tachycardia, blood pressure fluctuation, urine retention, tachycardia and blood pressure fluctuation. Okay, but in this, bowel, bladder, and sexual dysfunctions are very common. Okay, particularly when the lesions is at the level of thoracic vertebrae, thoracic segments. Respiratory involvement, it is commonly involved. In severe cases, it is rarely involved here. Okay, unless there is an extensive spinal cord involvement or higher cervical nose. Right. Prognosis. So in the GBS, the recovery starts after weeks or months. 80% have good prognosis. Okay, 5% lead to mortality and due to respiratory failure, as I said. Long-term disability in 20% patient, that is residual, can land up into CIDP. Right. And here the recovery depends on the severity of the cause and the cause of the transverse myelitis. 1/3 of the patient recover fully, right? 1/3 patients. Okay, 1/3 have moderate deficits, and 1/3 have significant disability for life. Okay, so chronic complications like spasticity, pain, bowel and bladder dysfunction are common in the cases of transverse myelitis. Now coming to the management, so in GBS, how do we manage? By giving IVIG. The dose is 0.4 grams per kg per day for 5 days, or 2 gram per kg at whole dose. You can go give up to 5 days that dose, or per day you can use 0.4 gram per kg. Other than that, Plex, both have equal efficiency, but IVIG is preferred more, right? Plex 4 to 6 exchanges over 1 to 2 weeks has to be done. Okay, other than that, supportive care for respiratory and autonomic dysfunction, physical therapy, rehab. Okay, physical therapy and even heparin is necessary to prevent DVT, because they will be completely immobilized, right, because of the paralysis. And coming to the TM, the management is mainly glucocorticoids and okay, so glucocorticoids, prednisolone we can use 1 gram per day IV for 3 to 5 days, right? Other than that, we can use IVIG and Plex also, and supportive care, right? Now outcome. So GBS has good outcome with treatment. Most patients recover with minimal residual effects, right? Some may have prolonged weakness or fatigue, but the ratio is very less. Only 20% patients will have the chronic complications, and recurrence is very rare. But if you see in the TM, it is variable. Some patients recover fully, while others may have permanent disability, and there is relapses or recurrence possibilities, right? Especially if there is a associated with other autoimmune disorders, right? So this was the difference. We'll see what are the key differences. So location, as I said, GBS affects the peripheral nerves, TM affects the central nervous system, that is spinal cord. Clinical presentation, GBS typically presents with ascending muscle weakness starting from the legs, while TM, if you see, it's sudden onset weakness or paralysis below the specific spinal cord. So it all depends on which segment is affected. Okay, and GBS, if you see, it can involve the cranial nerves and respiratory muscle also. Okay, but TM more likely involves bowel and bladder and sensory levels corresponding to spinal cord lesion. CSF differences, as I said, albino cytological dissociation will be there, that is high protein but normal cell count. But in DM there will be pleocytosis with elevated protein. Okay, GBS has better prognosis with complete recovery in most cases, but TM has variable prognosis, with some patient landing up to permanent disability. So this was the differences between Guillain-Barre syndrome and transverse myelitis. Thank you.